So hello and welcome everyone. I'm Carrie Randabolio, Provincial Coordinator Knowledge Mobilization here at the Alzheimer Society of BC and Yukon. I'm joined today by Dr. Sarah Wu, our Strategic Lead Research. Also with us is our co-op student Olivia, who will be keeping an eye on the chat. So please pop any questions you have in the chat box. And we'll be keeping track for the Q&A to follow our guest presenters' presentations. We also understand that the topic of diagnosing dementia can be sensitive for some. We encourage questions and curiosity, and we ask that you please keep in mind that this webinar is a public recorded space. When using the chat, be mindful of any personal information or stories that you're sharing. Each person's experience with dementia is unique. Please speak to your doctor or other qualified healthcare provider to address questions specific to you or the person you're supporting. You might have noticed something a little bit different about our name and logo. As of February 2026, we are the Alzheimer's Society of BC and Yukon. Since 2023, we've been operating our first linked dementia helpline in the territory. And as we continue to grow our services for Yukoners, we've taken to heart that our name needs to better reflect who we are, what we do, and who we serve. We're committed to changing the conversation about dementia, changing the experience of living with dementia, and changing the future through research, advocacy, and community action across British Columbia and the Yukon. Bringing us back to research, we're so excited to be joined by Dr. Mari DeMarco and Dr. Natanya Russek today for the latest updates on the science of Alzheimer's disease biomarker testing and its role in early detection and timely intervention. Dr. DeMarco is a clinical chemist at St. Paul's Hospital and clinical professor in the Department of Pathology and Laboratory Medicine at the University of British Columbia. Dr. DeMarco's research group aims to create better tools for timely diagnosis of Alzheimer's disease, frontotemporal degeneration, and related disorders, and make these tools easily accessible to those who need them. This research is accomplished in close collaboration with clinicians and scientists at UBC's Clinic for Alzheimer's Disease and Related Disorders. Dr. Natanya Russek is a UBC Behavioural Neurology and Dementia Fellow and Clinical Instructor with UBC's Division of Geriatric Medicine. She earned her medical degree at the University of Wisconsin School of Medicine and Public Health and completed residency training in internal medicine at UBC. She then completed fellowship training in geriatric medicine, followed by a subspecialty training in behavioral neurology and dementia. Her clinical practice includes caring for older adults in hospital and in outpatient clinics at St. Paul's Hospital and the UBC Clinic for Alzheimer's Disease and Related Disorders.
Thank you, Carrie, for that kind introduction and really helping to set the stage for today's talk. I'm going to start us off, but I'm so pleased to be joined by my colleague, Dr. Russek. I'm going to provide a bit of an introduction to the biomarkers, and then Dr. Russek's going to go into much more detail. So I'll start us off with sort of what the biomarkers of interest are in blood, what do the results mean, and then, as I mentioned, I am fortunate that I get to pass it off to Dr. Russek to go into the details of who testing is appropriate for, who it's not, when when is it appropriate, and when is it not, based on our current knowledge of this test. Okay, so as I said, we'll get started on this first one. And to help us set the stage, let's first talk about what is a biomarker for Alzheimer's disease and what is a biomarker in general. So in the context of Alzheimer's disease, it's some substance in the body that provides a measure of the changes occurring in the brain as a result of Alzheimer's disease. And so most of you are probably familiar with biomarkers in other contexts and other disorders, like in diabetes. Glucose is a biomarker for diabetes. Cholesterol is a biomarker for heart health. And so in Alzheimer's disease, we're going to be talking about some particular biomarkers. One being types of amyloid beta peptides and tau proteins. So we all have these peptides and proteins in our brain, and our cerebrospinal fluid, and in our blood. It's just that their level changes with Alzheimer's disease, and we use that change in the amount of these biomarkers to inform about the presence or absence of Alzheimer's disease. So just to give you a little bit more specifics, I'm going to be talking about these amyloid beta peptides. You'll see some numbers next to them. That tells us the size of these peptides, how short or long they are. And then for the tau proteins, we're going to be talking about all tau proteins, so total tau, but we're also going to be talking about specific forms of the tau protein. And there'll be some numbers next to that, and it tells you where along the protein there's some modification occurring. Okay, so let's first look at disease development, sort of what's going on in the brain to kind of give us a foundation. And so as a result of Alzheimer's disease, we get the formation of these amyloid plaques and tau tangles as disease develops. So you have these amyloid plaques forming outside the cells and these tau tangles forming in the cells in the brain. Again, these come from proteins we all have. It's just that this deposition is abnormal. This aggregation of these things is abnormal. So these orange amyloid plaques, these are formed of the amyloid beta peptide, predominantly this form that's 42 amino acids long. So that's why we refer to it as amyloid beta 42. And then we have tau tangles that are formed of tau proteins. These tau proteins can be modified in Alzheimer's disease. They can be phosphorylated. And so phosphorylated forms of these tau proteins are often a biomarker for Alzheimer's disease. Okay, so going from the brain, let's go to the fluids surrounding the brain. And let's look at what signatures might be left in cerebral spinal fluid based on what's happening in the brain. So when we look to cerebral spinal fluid, we see actually a decrease of amyloid beta 42 in persons with Alzheimer's. So as these plaques form, it's kind of sopping the amyloid beta peptides out of cerebral spinal fluid so it can be recruited into these plaques in the brain. So we see this decrease of amyloid beta peptide 42 in the cerebral spinal fluid of persons with Alzheimer's disease. For tau, the opposite happens. We see an increase. So as these tau tangles form inside the cells, it damages the cells, and that injury or even death of the cell will cause the tau to be released and flow out into cerebral spinal fluid. Hence, we see this rise. And so we see a rise in all tau forms. So I mentioned total tau. That's just kind of all the tau species that are in the cerebral spinal fluid. And then a key marker in cerebral spinal fluid is a specific form of tau phosphorylated at residue 181. So 181 is kind of like a address on a house address on a street, and it tells you where along the street you are. So for tau, this 181 tells us where along the protein the modification is occurring, and that phosphorylation I have represented here by the letter P. And so we see these changes, and I want to kind of focus even more, give you even more specifics, that we really look to compare these to the pathology that is most distinguishing for Alzheimer's, and that's the formation of amyloid plaques. So even though we're talking about tau, still overall we're saying, what are the biomarkers that tell us whether or not these amyloid plaques are present or not? And that involves both amyloid beta and tau. They're really tied together. And the reason we need to identify these amyloid plaques is because that's what's specific to Alzheimer's pathology. You also have those tau tangles in Alzheimer's pathology, but those aren't specific to Alzheimer's. Okay, so in cerebral spinal fluid, what are the best biomarkers we have? It turns out that it's a combination of these biomarkers. So it can be any of the following ratios: phospho-tau 181 over amyloid beta 42, total tau over amyloid beta 42, or amyloid beta 42 over another form of amyloid beta 40. And what you can see is they all have amyloid beta 42 in common. In cerebral spinal fluid, amyloid beta 42 is a critical marker. Based on our evidence today, these are the best. You can use any of these ratios. They all perform very similarly. And so you might, depending on where you are, you might, wherever your testing is sent, you might have one or a couple of these, and it might be different in a different jurisdiction. But we know they all perform similarly. I'm not going to go into too much more detail of this because I really want to move on to blood. But I've given another talk in the past, so I'm sure we can link to that on cerebral spinal fluid if you want more detail about this particular testing. But let's go on to blood, because that's really where the newest data is coming out about biomarkers. So again, looking in blood, what is a signature we see in blood? Well, again, we're really focused on what biomarker signatures are telling us if there's amyloid plaques present in the brain or not. And we see kind of what we see in cerebral spinal fluid. We see a decrease in amyloid beta 42 peptides and an increase, and here I've noted phospho-tau in particular, in blood. Okay, that all looks similar, but next I'm going to show you there's some key differences between blood and cerebral spinal fluid. First, amyloid beta is changed, but the decrease is far less discriminatory than it is in cerebral spinal fluid. So that makes it really challenging to measure. With blood, p-tau, we see an increase, but it's not, again, as big as it is in cerebral spinal fluid. And also, we've changed our street address, right? We used to be looking at 181 in blood. Now we're looking at 217. So when you look at this, I think it kind of stands out to you that, oh, maybe this p-tau marker looks better than the amyloid beta 42. So even though we're talking about amyloid plaques, it still turns out that this p-tau marker is a good marker of the presence of amyloid pathology. So the best biomarkers we have in blood are actually not multiple biomarker, it's a single biomarker. So we'll cross out that X. The best biomarker as of to date, March 4th, 2026, based on current evidence, is p-tau 217 in blood. It's the most accurate biomarker we have presently. You might see it alone or as a ratio. So you might see it as p-tau 217 to total tau, also known as the percent p-tau 217, or p-tau 217 to amyloid beta 42. Now, p-tau 217 on its own is a really good biomarker, and combining it with some other biomarkers might have some modest improvements. It also has other complications, which is, a full other talk. But just to know that p-tau 217 on its own is a very good biomarker, and you might see it in combination with some other things. You might also see some other biomarkers mentioned, some other street addresses in addition to 217, 231, 181, but you can kind of ignore that. Right now, the best evidence we have is for 217 being the most accurate biomarker we have for identifying Alzheimer's pathology using blood. Okay, so now that we have that, let's summarize a little bit. So we have a blood test that measures this form of tau called phosphorylated tau at 217. And we know this is increased in Alzheimer's disease. This test is good, but not great at telling us about the changes going on in the brain as a result of Alzheimer's disease pathology. And because it's good, but not great, it's not perfect, this testing may need to be followed up by additional testing, like the more accurate cerebral spinal fluid testing, or depending on where you live, you might also have access to amyloid PET imaging. So that's imaging of the brain using a special tracer. And so you might need that to help better figure out whether you have a biomarker signature consistent with Alzheimer's disease. But whether it's blood or cerebral spinal fluid or imaging or all of them combined, the results would be used by your doctor in combination with a lot of other evidence to help determine if the individual has Alzheimer's disease. They're not used on their own to figure out yes, no, Alzheimer's disease, yes, no. It's really a combination with other factors. Okay, so we've seen what the key biomarkers are. Next, we're going to look at what the results mean. And you're actually going to get a chance to interpret some blood biomarker results. So pay attention so you can try and do your best at interpreting these tests. Okay, so we're going to put Alzheimer's disease to the side for a second because I want us to get all on the same page about the performance of blood tests. So we'll just set that Alzheimer's pathology and Alzheimer's biomarkers to the side. Let's imagine that you have a blood test that measures whether or not a person likes country music. Okay, we're going to make an imaginary protein that we all have in our blood, and we're going to call it the Twain protein. And we're going to say this Twain protein, like our p-tau217, is increased in the condition we're looking at. And this condition is whether or not you like country music. So people who like country music have a lot of this protein. And so how this research would have worked to figure this out is we would have figured out that very little amounts of this protein are associated with persons who don't like country music. And for people with a lot of protein, a lot of this Twain protein in their blood, that this tended to correlate with people that loved country music. And so you can imagine that this also looks like this, where a researcher would have tested this on a lot of people who don't like country music, and they would have found very low amounts of this protein in their blood. And then they tested a bunch of people who loved country music and found that there was a lot of this protein in their blood. Now, if this is a perfect test for country music, as we've shown here, you can draw a line between these two populations and figure out really easily who does or doesn't like country music. So this is an ideal world. Most tests do not work like that. And that's because there tends to be overlap between these two groups. And this applies to almost every test we measure, protein we measure in blood and tests we report for medical care, that there tends to be overlap between the two different groups. And so here you can still draw a line between them and get fairly good accuracy for figuring out whether someone likes or doesn't like country music. So if we do that together, we can say, look at this person over here. They have a high amount of this protein. We're very confident that they are a country music lover because they have a lot of this protein. They're well above that cut point. And go the other way, someone with very little protein, we can be very confident that they are not a country music lover. But it's this people in the middle that we have less certainty. And this is where your doctor weighs in and includes other factors as well in deciding, what are the next steps in the care and what this likely means as far as your affinity for country music in this case. Okay, now that we have sort of a baseline on how tests usually perform, let's go back to our Alzheimer's disease blood tests and our p-tau217 marker. Like the Twain protein, we know that this one is elevated in Alzheimer's disease. But now let's look at how good this test is and what the results really mean. And this will help us later on when Dr. Rusek's talk, because it'll help inform also why there's sort of settings where this is appropriate to be used and settings where it's not appropriate to be used. Okay, so again, similar to our Twain protein, now we're flipping over to our p-tau217 protein, and we want to look at our populations. We have populations that don't have Alzheimer's disease, that have Alzheimer's disease, and in a perfect world, these populations would be completely separated. We could draw a line between these two and say anybody with p-tau217 over this blue line would be consistent with Alzheimer's disease, and anyone below this wouldn't be consistent with Alzheimer's disease. But as I mentioned, things rarely work out that perfectly, and there's usually some overlap. Now, an added layer of complication here is we're not trying to figure out the difference between someone coming to their doctor who's completely healthy, no brain health concerns, versus someone coming because they have concerns that they might have Alzheimer's disease or they're having some challenges with their brain health generally. Really, how this test is meant to be used and where it's been most studied is people presenting with the signs and symptoms of Alzheimer's disease, so some level of cognitive impairment. So you have a patient presenting to their doctor with some level of cognitive impairment, and then the doctor's trying to figure out what is the underlying cause of that cognitive impairment. Is it Alzheimer's disease? Is it another neurodegenerative disorder? Is it some other cause, perhaps? And so it's not as simple as dividing between a completely healthy person and individuals with Alzheimer's disease. And because of that, we actually see even greater overlap between these groups. So now if you're staring at this, you can imagine it's quite hard to draw a line between these two groups. Or if you did, the test wouldn't be all that accurate. So how we get around that is actually drawing two lines. So with these blood tests, draw one line above which you have high accuracy for those groups being consistent with having the presence of Alzheimer's disease pathology. And then you draw a lower line below which you're highly confident that individuals below that line are unlikely to have Alzheimer's disease pathology. But that then leaves these people in the middle here. So people with this sort of middle ground and p-tau2 levels in the blood, we actually don't know, right? As you're looking at this, it's really hard to tease out who might or might not have the pathology of interest here. And so we actually don't know. And these people are the ones particularly that would require further workup to help determine if they do have a biomarker signature of Alzheimer's disease, that being perhaps going on to cerebral spinal fluid testing or amyloid PET imaging. So with this in mind, I'm going to enroll your help to help interpret some blood test results. So let's imagine a concentration amount of p-tau217 on this end of the spectrum. What do we think? How might we interpret this blood test result for this individual? I'm going to add in my cut points. Okay, so we see it's well below this orange line. And so the interpretation of this result would be that it's not consistent with the presence of Alzheimer's pathology. Let's imagine another scenario, someone on the other end of the spectrum with a lot of phospho-tau217 in their blood. What would be the interpretation for this result? Again, we'll add back our cut points. We see it's well above this upper cut point. So we have high confidence that this amount of p-tau is consistent with the presence of Alzheimer's disease pathology. I think you know what's coming next. What about a person in this middle range? We add our cut points back and we find that they're between these two cut points. This would be considered an intermediate value. We really need more information to help figure out what's going on here. So again, this might be an individual who they might recommend go on to cerebral spinal fluid testing or amyloid PET imaging. We really don't know the results, any kind of interpretation. So we call this an intermediate result for this type of concentration where we found in the blood. So let's go back to our summary. We have blood tests now that measure p-tau217, and we know that this marker is increased in Alzheimer's disease and can help distinguish Alzheimer's from other neurodegenerative disorders. The test is good, but as we shown above, a lot of overlap, right? So it's not great. It's not a perfect test, but it can, with those two cut points, help us rule in or rule out Alzheimer's pathology. But because of this overlap and this intermediate range, an individual may need to go on for further testing. And as you can see, because it's a good but not great test, it's not used in isolation. Your blood test, cerebral spinal fluid test, imaging, and as you'll hear Dr. Russek describe, a lot of other clinical information goes into deciding and helping determine if a person likely has Alzheimer's disease or not. And so in summary, we've looked at the key biomarkers in cerebral spinal fluid and in blood, and they're a little different. We've looked at how to interpret for these new blood tests, what a result might mean. And now I'm very happy to pass it on to my colleague, Dr. Russek, who's going to tell us a lot more about the specifics of who should not get testing, when and when not. And so I'll pass it off to you, Dr. Russek.
Thank you so much, Dr. DeMarco. I love the Twain protein analogy, and I think it was a great comparison. So let me pull up my slides, and we're going to talk about some clinical context for all of the wonderful detail that Dr. DeMarco has outlined. All right, so we'll get started, and we're going to kind of go through these topics together of who testing is recommended for and when is testing recommended over the course of an outline going through how we do a clinical assessment, and then we'll go through some questions that will help us explore these concepts, and then we'll go through some example patient cases with pretend patients. I'm a geriatrician and I work at a number of the clinics in the Lower Mainland in Vancouver, including at the Alzheimer's clinic at UBC. And when we make a diagnosis of Alzheimer's disease, we spend a lot of time with patients. It's actually a real luxury I find in our specialty. I spend over an hour with each of my patients on the first assessment. And that's because we go through a very comprehensive history with the patient and often with their loved ones that are coming with them to the clinic. We will go through a history that includes their medications, their medical history, if they're needing any support in their daily life to do what we call activities of daily living, things like taking care of their personal care, driving, cooking, cleaning. And we'll also go through a review of all of the areas of cognition, things like memory, language skills, visuospatial skills, which is navigation in space and where we are, our sense of ourselves in space. And then we do a physical exam, and this usually is a neurological exam as well as some other general examination components to look for any other neurological or other findings that could help us figure out what exactly is the cause of the patient's cognitive or memory and thinking problems. And then we also spend a reasonable amount of time doing a cognitive assessment. And this is usually with paper and pencil tests that we do in the office. And the goal here is to corroborate or essentially look at all of the different areas of the brain with a more objective measure. So we look at things like memory and language and visuospatial skills using paper and pencil testing. And then we correlate that back to what the patient and their family members reported as symptoms. When we identify that somebody has some cognitive or memory and thinking impairment, then we can talk about their level of function and how this is impacting their daily life and talk about a diagnosis of something like dementia or mild cognitive impairment, which are labels that we give to describe somebody's cognitive symptoms. There are many different additive tests that we use in the comprehensive clinical assessment in order to make a diagnosis of cognitive syndromes, things like mild cognitive impairment or dementia, and to try to figure out what is causing these symptoms. And Alzheimer's disease biomarkers, as well as other biomarkers in general, are increasingly being used in the clinic in order to support what we as the clinicians think could be causing an individual's cognitive symptoms. Guidelines and society recommendations actually state that all patients with cognitive symptoms should have some sort of imaging of their brain. Usually it's a MRI or a CT scan. And we do actually consider this a biomarker. This is a biomarker because it's a biological measure of the disease process that could be going on in somebody's brain. There are many other types of biomarkers that are used specifically in the diagnosis of Alzheimer's disease. And this talk, which Dr. DeMarco already outlined, talks mainly about the newest biomarker that has become available recently for Alzheimer's disease, and that's blood-based biomarker testing. What's really important is that not everybody who has symptoms or concerns even should have blood-based biomarker testing. So what I'm going to outline over the next couple of slides are some really key points and questions, food for thought, that I go over with my patients in the clinic when thinking about the role of these tests. So there's three main times that I find that blood-based biomarker testing for Alzheimer's disease can be helpful. The first one is to confirm that there are Alzheimer's disease changes in the brain in people who are early in the disease course. So people who have mild cognitive impairment, meaning they are independent in their daily life but have some cognitive symptoms, or people who have mild dementia. Maybe they no longer drive or they need assistance with their finances, but otherwise they're fairly independent. The reason that we recommend doing these testing in these individuals would be to confirm or support what we think is going on, which would be underlying Alzheimer's pathology or brain changes that are causing these clinical symptoms, the experience of the patient. The second time that these blood-based biomarker tests is helpful is when it's not really clear what's causing the cognitive symptoms. Some people present somewhat atypically. This is more common in younger people or in people who have multiple medical problems or comorbidities that may cloud the picture. And sometimes even the most seasoned of my mentors have a hard time figuring out what could be the possible underlying brain changes leading to somebody having dementia or cognitive symptoms. In those cases, testing for Alzheimer's disease using a biomarker can be really helpful to rule in or rule out Alzheimer's disease as a cause of the patient's cognitive symptoms. The last and newest probably point about blood-based biomarker testing is determining if somebody can qualify for anti-amyloid antibody therapy. And we could spend an entire hour just going over this therapy, but in brief, this is an intravenous infusion therapy that has been approved in Canada. That what it does is it removes some of those amyloid proteins that Dr. DeMarco was mentioning from the brain. And it's only approved for people who have confirmed Alzheimer's disease changes in their brain and have symptoms. So in these people, even if they have very classic Alzheimer's disease symptoms, we do need to confirm the biological change in their brain before we can give them this medication, because the medication really targets the specific pathology or brain changes that cause Alzheimer's disease. There are also many times that testing for blood-based biomarkers for Alzheimer's disease is not helpful. The main takeaway from this point is if testing for Alzheimer's disease will not change what we do, generally, I, as well as guidelines, do not recommend doing this test. Unfortunately, this really highlights how limited our treatment options are for Alzheimer's disease right now. That new medication that I mentioned, the anti-amyloid infusion therapy, it has a lot of limitations. Most people are not eligible for it. It's expensive, it's time intensive, and only the most earliest patients with the earliest symptoms are eligible for it. So there's a lot of other people that I see in the clinic, people in the community living with symptoms of Alzheimer's disease that do not meet that early stage criteria. So there's actually a lot of people for whom this testing would not be recommended. Going through the different points on this slide. So when dementia is advanced or the cognitive symptoms are advanced, we do not recommend this testing. And that's really because it won't change what we do. That is generally because, as I mentioned, people have to be very early in disease course to be eligible for the amyloid therapy. And also, as Alzheimer's disease progresses, our clinical certainty about what is causing someone's dementia symptoms goes up, because as people progress, they will kind of progress through generally a predictable pathway of symptoms. And we can use that to support our suspicion that the changes in somebody's cognition and function are due to Alzheimer's disease. A second time that testing for Alzheimer's disease biomarkers is not recommended is if we really don't think it's Alzheimer's disease. These tests, as Dr. DeMarco mentioned, were tested on patient populations that were suspected to have Alzheimer's disease. We have not tested the performance, and there's no reason to believe that these biomarkers would be helpful for patients who have a disease causing their cognitive impairment that's not Alzheimer's disease. We can talk later about other types of testing that is down the line, but for our purposes today, this specific p-tau 217 testing is not recommended if somebody is not thought to have Alzheimer's disease. Number 3 here is testing for Alzheimer's disease is not recommended if the person has not also had a very comprehensive clinical assessment. That's because there are many different things that can cause dementia and cognitive impairment, and really making sure to have that comprehensive overview, like I outlined at the beginning with the history and the physical examination and the cognitive testing, is what gives us a sense of how likely it is that somebody could have Alzheimer's disease, and then it can inform us if it would be useful to do this testing. The last point is that blood-based biomarker testing and biomarker testing in general for Alzheimer's disease is not recommended in a person who's not having any cognitive symptoms, which we'll talk about on the next slide. So, why is it? Why are people who do not have symptoms not recommended to get this testing? There's a few key points. The first point is that even if somebody tested positive for p-tau 217, before they had any symptoms, we cannot predict when or even if those individuals will develop symptoms. All we know is that from looking at big population studies, that people who would test positive for p-tau 217 before having symptoms are at elevated risk of developing cognitive impairment, but it doesn't actually change what we do. Most of the individuals who would be curious to have the biomarker testing for Alzheimer's disease and have no symptoms, they have a family history or they're already worried about their cognition. And those people, I tell them the same brain health strategies I would tell anyone. And unfortunately, right now, we do not have any treatments or therapies to prevent or delay the onset of these cognitive symptoms. There's some studies ongoing looking at the use of these new amyloid removing treatments in people who do not have symptoms, but we're waiting for some of that research to be published. Secondly, is that there are sometimes false negative results. So that's what Dr. DeMarco was talking about, where people could actually have Alzheimer's disease in their brain, but test negative on the p-tau test. And that's why it's really important to really think critically about the use of these tests and have a discussion. I always have a discussion with my patients and their family members in detail. As I mentioned, the result of these tests in people who do not have symptoms won't change what we do. We don't have any medications to prevent the onset of clinical symptoms. And sometimes this can raise really a lot of worry. And unfortunately, there's a lot of uncertainty when it comes to cognitive impairment and what the future might hold. And when people already are worried, I make the recommendation that unfortunately the science hasn't caught up to our observations quite yet. And we recommend lifestyle strategies and keeping on top of your general health and having a good relationship with the rest of your healthcare team. And we'll see what the future will hold. But for right now, these biomarker tests are not recommended for people who do not have cognitive symptoms. There's a few important points that piggyback on what Dr. DeMarco kind of outlined earlier from a clinical context. So, blood-based biomarker testing does not do a few things. It does not equal a diagnosis of Alzheimer's disease or dementia. Those are essentially clinical diagnoses that are made, again, with that comprehensive meeting with a trained clinician. And the biomarker tests are used to support our clinical assessment. Having a positive test does not mean that somebody will have symptoms, like I mentioned about this is why we don't test in people who don't have any symptoms. And it also is not related to the symptom severity. So the higher the p-tau test does not mean that somebody will have worse clinical symptoms or be later in their disease stage. There's a few key questions that I would recommend that anyone think about before they decide to go forward with these testing. And this is what I talk about with my patients in the clinic on a very frequent basis. So the first is, how will it help the individual, their family members, to know whether or not their cognitive symptoms are due to Alzheimer's disease? And that is actually, I think, a question that often requires a lot more thought because in the clinic, many times we can have a pretty good level of certainty about, suggesting, oh, I think your cognitive symptoms are due to Alzheimer's disease. The question here is how important is it to have more certainty about Alzheimer's disease being the underlying cause? And for most of my patients, that tends to be a very personal decision that they tend to think about with their family members. A really important and frustrating point is that middle zone of people, the uncertain result. One question that I talk to my patients about is, what would you want to do if your result falls into the uncertain zone? Would you want to have additional testing like a spinal tap or a lumbar puncture? Would the test of time or waiting and watching be sufficient? What if the result doesn't match what we think is going on? So if we have a patient we think has Alzheimer's disease, but the test is negative, would you want to then go forward with the spinal tap or additional testing? This is something that I think is really worth thinking about before getting the result, because having an uncertain result is quite stressful and uncertain and can really influence somebody's decision making in that moment. And then lastly, Is somebody eligible for the anti-amyloid treatment? And would you want to go through the process of getting worked up and becoming eligible for that therapy? And then going forward with the therapy, it's an every other week IV infusion. It requires a lot of monitoring with MRIs, etc. So I do always explain the anti-amyloid therapy when talking about or considering going forward with blood-based biomarker testing. All right, so I'm going to go through a couple of cases. As I mentioned, these are all totally made up with photos from AI, but I hope that these will be helpful examples and may resonate with some of you from people that you know. And I hope that this will be a good fodder or talking points for you to bring up with your own physicians or healthcare providers. So the first patient here we have is Miss W. She's a 75-year-old woman who's working as a lawyer, and she lives alone in a condo on the West End by herself. She does not have any assistants in her home, and she does not have any cognitive symptoms. She says she's totally fine, maybe the occasional word finding problem, but it doesn't get in the way of what she wants to do. However, she has a very strong family history of Alzheimer's disease, so she comes to her primary care provider to talk about her risk, and she asks about doing blood-based biomarkers for Alzheimer's disease. Okay, so for a patient like this, Alzheimer's disease biomarkers are not recommended because she has no symptoms. She has not been diagnosed with mild cognitive impairment or dementia. Next, we have Mr. X. He's a 72-year-old man with 1 or 2 years of short-term memory problems. He's misplacing some items. He's kind of forgetting what he wanted to say in the conversation, having difficulty keeping track of appointments. So he goes to see his primary care provider who does a cognitive assessment and diagnoses him with mild cognitive impairment. And they think it might be due to Alzheimer's disease because his primary symptom is memory impairment. So when it comes to possible roles for Alzheimer's disease biomarkers for Mr. X, there's two possibilities. One would be to support the diagnosis of Alzheimer's disease as causing his cognitive symptoms. And just on this point alone, that's something Mr. X might want to think about or talk with his primary care doctor about, or maybe some of his loved ones about. Also, given that his symptoms are very mild, he's independent, he's still driving, he does his own banking and shopping, he might be eligible for the new anti-amyloid infusion therapy, for which he would need to have Alzheimer's disease biomarkers showing a positive result. So the next steps is if he's interested in getting testing, then he should talk to his primary care provider about getting referred to a dementia specialist. That could be a neurologist or geriatrician in the community, or it could be at the Alzheimer's disease clinic at UBC. Next, we have Ms. Y. She's an 80-year-old woman with 5 or 6 years of cognitive symptoms, and her symptoms are more advanced. She's asking questions most of the day of her family members. She's texting her loved ones often because she can't remember what the plan was for that day or what the schedule is. And she has people who are coming to her home to help her with things like cooking and cleaning, and also once weekly assistance for shower care. She presents with the assistance of her family to see a psychiatrist in the community, and this person does a cognitive assessment. And she is diagnosed with dementia at the moderate stage. So this is a more advanced stage. And they also think that this is likely due to Alzheimer's disease because the primary and initial symptom, as well as the most severe symptom, is memory impairment. Okay, so what are the possible roles of Alzheimer's disease biomarkers for Mrs. Y? They would not be recommended in this patient because it would not be recommended to do these tests in individuals who have advanced dementia symptoms. As we talked about, doing this testing will not change what we do. Patients who have more advanced symptoms are not eligible for the new anti-amyloid therapy. And as people advance in their disease, the diagnosis often becomes more clear. So this test does not add to their clinical care. The last patient we have is Mr. Z. Oh, Zed. I'm in Canada. This is a 69-year-old man who has 2 to 3 years of cognitive symptoms. And he has a complicated medical history where, he's been admitted to the hospital a couple of times in the past for strokes. He's on multiple medications for high blood pressure and diabetes. And he was referred by his primary care provider to see a geriatrician for a cognitive assessment because he's been having more difficulty keeping track of the finances. There was an issue where he almost fell prey to a telephone scam, and he's been having more difficulty with following through with the usual recipes as he's usually an avid cook in the kitchen. And the geriatrician does a comprehensive assessment and feels that this patient meets criteria for a diagnosis of dementia. And although he has a milder stage, given his cardiovascular risk, as well as the type of symptoms he has, which are more about planning and managerial tasks rather than memory symptoms, the doctor suspects that he has dementia due to cerebrovascular disease, or the prior strokes and markers of high blood pressure and diabetes that can often be seen on people's brain scans. So, what are the possible roles of Alzheimer's biomarkers for Mr. Z? They are not recommended because there is a better alternative cause suspected for this patient's cognitive symptoms. So, as I mentioned earlier, we do not recommend doing Alzheimer's disease biomarkers in individuals who have cognitive symptoms due to a disease that is not Alzheimer's disease. All right. So there's a few key points that Dr. DeMarco and I have tried to go through together. I think this is really a very exciting time in our field and a really exciting time to be advancing the care for patients with cognitive symptoms and their family members and really improving the accuracy of our clinical diagnoses. But it's important to know that these tests do have many limitations. They're importantly only recommended in people who have cognitive symptoms. And I recommend that you start by you or your loved one, if you would like to talk about these tests or somebody that you know or yourself has cognitive symptoms, start by talking to your primary care provider about it. And if there's interest in doing these testing, then I would recommend that you ask them about a referral to a specialist who takes care of people with cognitive impairment. So that would be a neurologist, a geriatrician, a psychiatrist, and of course, we're always happy to see people at the Alzheimer's Clinic at UBC. All right. So I want to thank everybody. This has been a great honor on behalf of myself and Dr. DeMarco, and thanks to the wonderful organization of the Alzheimer's Society of BC and Yukon. And we're hoping to take some questions.
Amazing. Thank you so much, Dr. Russek and Dr. DeMarco. Okay, so we'll jump right into it. Dr. DeMarco.
I wanted to take the opportunity to maybe ask the first question, if that's all right.
Go for it.
For Dr. Russek, I'm just thinking of, maybe a patient that kind of fits with some of your descriptions, and they have maybe a patient or maybe it's their loved one that might be having some symptoms. Would you advise them to press their primary care provider to order this test?
It's a really good question because technically a lot of these tests are available to any physician or health primary care provider in the province. However, because these tests really have to be taken in the context of a comprehensive assessment, I strongly recommend that primary care providers do not order this test. And it's not because they're not able to know about this and have the discussion with their patients. It's honestly the biggest limitation is time. And I'm gifted with a real luxury of time in my clinic, as are my colleagues in neurology and geriatrics and psychiatry. And we can sit down and have a comprehensive assessment, go through all the risks and benefits. And it's really hard to undo doing a test. Once you do the test, you have to deal with the answer. And if there's a lot of uncertainty or that answer doesn't match with what was expected, you're going to come and see one of myself or my colleagues anyway. So I recommend starting with a specialist referral up front.
Great, thank you.
Yeah. Can I ask a question of you as well? So I know there's a lot that's changed only in the last couple of years. So just 2 years ago, Dr. DeMarco, you gave the talk about cerebrospinal fluid, and today you're giving the talk about blood-based biomarkers. Do you think there's some new way to test for Alzheimer's disease that's on the horizon?
Oh boy, that's probably outside of my scope. I'm still working on the blood tests and making them really robust. And we're learning, I think even in the blood, well, we have these tests, right? And they are accessible to people, that we're still learning a lot about them, right? And all the sort of nuances of this testing and how they might be best used. So my focus is really on that and making that a really great test. And then hopefully, I think the next thing on the horizon, hopefully we can help support other diagnosis of other neurodegenerative disorders, right? A lot of our biomarkers are for Alzheimer's and other disorders like frontal temporal dementia and Lewy body dementia and Parkinson's disease dementia. We've really kind of lagged behind in being able to offer biomarkers. So really hoping that that's where some of the advancements can be made to maybe level the playing field a little bit for everybody experiencing some of these challenges with their brain health.
Great. Thank you. Okay, so I'll just maybe ask a question from one of our participants. Um, this is early stages, but I'm just wondering if there are any known, racial differences in blood-based biomarker testing, and if so, how might that impact someone's decision to go ahead with the test?
Yeah, that's a great question. And I think also just, in this forum, a great question to bring forward to make sure it's top on everybody's mind as this field moves forward. So I think the original question related to Black Canadians, I can say
Mhm.
there's not a lot of data there, in part because there's not a lot of research cohorts. So that's something as a field we really need to keep pressing forward, and I'm just pinging the Alzheimer's Society also to help keep that on the forefront. I know they're involved in a lot of research discussions, so making sure that we're funding research that's really investing in that. But there is data from other countries. So the US has done a few studies. The largest one I'm thinking of is almost 1,000 individuals, and they did not find significant differences between white and Black participants, including like in accuracy, but also, we went through that sort of diagnostic assignment in my talk. They found that they were concordant, that depending, your race didn't alter that interpretation. So that gives us a lot of confidence. At least in those groups. And of course, there's more ethnicities to look at. And I think those are coming out. I think every month there's like a new paper. So it is like evolving, but so far it's been fairly reassuring from an accuracy standpoint that it seems to be forming very similarly.
Okay, thank you. And yes, that is also on our radar as well to push diversity and populations forward. Thank you for that. Okay. And now, hopefully this question will answer there's been a lot of similar questions related to this. So hopefully this one captures a lot of what's in the chat. So can Alzheimer's biomarkers be used in people who have dementia due to other causes, such as Lewy body dementia or vascular dementia, for example?
Dr. Russek, do you want to field this one?
Sure. I'm happy to take it. So, as Dr. DeMarco went through, p-tau 217 and the other markers that we use are more specific to Alzheimer's disease. There's surrogate markers for that amyloid protein change in the brain, and that amyloid protein change is much more specific to Alzheimer's disease pathology or Alzheimer's disease changes in the brain. So, these biomarkers cannot be used in people who do not have Alzheimer's disease as their underlying cause for their cognitive symptoms. There's some more biomarkers that we're hoping are coming down the pathway. There's a lot in research, as Dr. DeMarco mentioned, for people with Lewy body or people with Parkinson's. There are other biomarkers that are being investigated, but unfortunately, these are the only ones that are clinically available, like outside of a research setting right now.
Yeah, and I would say that just to add that that's a downside of this. We talked about the p-tau 217, but it's also an upside because it is relatively specific for Alzheimer's disease. So, for instance, a patient that has symptoms that might be consistent with Alzheimer's or frontal temporal dementia, using this type of biomarker would help, I think, Dr. Russek or who's ever carrying them, like point them in a particular direction because it is relatively specific for Alzheimer's. So usually by the time you get to see Dr. Russek or a specialist, the diagnosis has been whittled down somewhat to a smaller differential, in which this might be helpful in the case that Alzheimer's is on the differential, but there is another neurodegenerative disorder also on the differential.
Great. Thank you. And I'm just trying to, combine questions together as best as we can so that everyone has their questions answered. I'm wondering, Dr. Russek, you outlined sort of a criteria that would, make someone eligible to have a blood-based biomarker test. I'm wondering if you could just briefly outline what that criteria would be. And then if someone was sort of suspecting that they wanted to have a paper-based cognitive assessment done, what would be the route to have that?
Absolutely. So the first part of the question is to be very granular about who should get this test, right?
Yeah.
So people should only get this test if they have clinical symptoms, if they've seen a doctor or another healthcare provider who's done a comprehensive assessment that includes a history, a physical exam, and cognitive testing. And then if they think that if their healthcare provider thinks that Alzheimer's disease is a possible cause, or is suspected to be the cause of the patient's symptoms. And then there's a couple of scenarios. So just because somebody has Alzheimer's disease and the physician or nurse practitioner thinks it's Alzheimer's disease doesn't actually mean that somebody has to have this test. If it's not going to change what's done, like it's not going to change the way that the patient or their family members plan for the future, for example, or if it's not going to change their eligibility for medications because possibly they're not eligible for the new anti-amyloid therapy, then those are reasons then people should not get this test. I don't think it's a necessary step right now for everyone who has dementia or other cognitive symptoms due to Alzheimer's disease. It's more or less like an option, something that can be discussed, and it's really an individual decision. And then the second question, can you remind me, it was about doing cognitive testing?
Yeah, so if someone's sort of suspecting something, changes in themselves or maybe a family member, what would be the process to starting that conversation?
The best place to start is to start with your primary care provider. And I know that there's a huge problem with getting access to primary care providers in our province. And it's a huge problem because the specialty clinics where I work do require a referral from a primary care provider. We do have a clinic at St. Paul's Hospital for people who can actually self-refer. It's called the Early Intervention Memory Clinic. So you can look that up online. It's for people who are worried about cognitive symptoms, but it's not for people who have dementia. It's more of a brain health clinic. But otherwise, people do need to start with a primary care provider in the community. And they will do sometimes the paper and pencil testing themselves. Many people don't have to be seen by a specialist.
Okay, amazing. Thank you so much. And I just want to take note of the time because we're 1 minute to 3 and we're ending at 3. So I just want to say if we did not get to your question today, my apologies. Please feel free to email the Research and Knowledge Mobilization team at the Society at research@alzheimersbc.org. And now we will move to the closing slides, if that's all right with everyone. Okay. I'm just going to bear with me, folks. I'm just going to share my screen. Hoping all of you can see that. Okay. So our team supports research recruitment, both provincially, but also nationally and internationally. Today, I have 4 opportunities to share with you. A team at the University of Northern British Columbia and the Center for Technology Adoption for Aging in the North is studying how remote monitoring technologies can help older adults live safely at home longer while supporting caregivers. Participation involves an older adult caregiver pair completing surveys and 2 interviews. And if you'd like to contact CTAN, please go ahead. I'm going to be throwing the details into the chat as well. Researchers at University of Victoria are exploring why people living with dementia request medical assistance in dying from the perspective of a family caregiver. This involves a 1-hour interview, and for more information, please contact Ashley. At the University of British Columbia, there's a team studying the information and service needs of dementia caregivers in smaller BC communities, so Comox, Courtney, Gibsons, and Sechelt. Participation includes a short questionnaire and a Zoom interview and an option for attending a focus groups. You can reach out to Julia Henderson's research coordinator, Emma, to learn more. And then finally, Dr. Allison Finney's team at UBC is hosting a Fireweed Club Nature Walk on March 13th from 10 to 12 p.m. at Pacific Spirit Regional Park. This is part of a larger study on how outdoor programming supports well-being for people affected by dementia. So this includes refreshments and lunch at the end of the walk. And if you'd like to attend, please reach out to Matea. So if you're wanting to learn more about dementia or wondering about our programs and services, please give our first link Dementia Helpline a call. Operators are there to support you in English, Punjabi, Hindi, Urdu, Cantonese, and Mandarin. Thank you so much for being with us today. We're so grateful you took the time to join us, and we truly value your feedback on how to make our Research Connects webinars even stronger and more engaging. So before we sign off, we'd like to launch a quick poll with 3 short questions. It'll just take you a moment, and we really value your input because it helps shape our future topics that we cover today. So if today's conversation has sparked your interest in research, we'd love for you to consider getting involved. Participating in research is a really powerful way to contribute to dementia knowledge and make a real difference, both in your community and for future generations. So you can learn more by visiting the I Want to Participate in Research section at alz.org, alzbc.org/research. We also genuinely love to hear from you. If you have questions about today's topic or any other ideas, please give us a shout at research@alzheimersbc.org. And don't forget that you can catch this recording and other recordings of our Research Connects webinar series on our YouTube channel anytime. And finally, a huge and heartfelt thank you to Dr. Murray DeMarco and Natanya Russek for sharing your expertise and passion on biomarker testing. We so appreciate your time and insights. So thank you again. We hope to see you at our next session.